Today's topic is the pharmacokinetics of anti-cancer drugs. And what does this mean? Well, first of all, cancer is a major health problem across the globe, and therefore, scientists and researchers are working on various ways to prevent this problem. To do this, discovery of anti-cancer agents was found by inhibiting metabolic pathways for cell division. But what does this mean? To do this, scientists need to study the pharmacokinetics of anti-cancer drugs, including the phrase called ADME, A for absorption, D for distribution, M for metabolism, and E for excretion. When a drug is administered exogenously, the mechanism of absorption focuses on how it will reach the target site. IV administration needs to be injected rapidly into the vein, where it undergoes the neuroabsorption phase and travels automatically into the systemic blood. But oral administration of drugs are usually lost before arriving at therapeutic sites due to various routes it can undertake. The drug undertakes a first-pass effect, where it is converted into a metabolite without appearing in the systemic blood. This involves dissolution of the tablet in the stomach and transportation to the gut. This is why oral administration exhibits a higher pharmacokinetic variability than intravenous agents. However, a small P-glycoprotein exists, PGP, which is a drug efflux pump encoded by ABCB1, which can be a major problem in its capability of drug resistance to cancer cells. So once we have absorbed the drug, where does it go? In the distribution phase, the drug travels to body tissues from the intravascular space to its targeted extravascular site. But variable drug distribution can be interfered by protein binding. This is not ideal in cancer patients, where only a free drug after released from its carrier is pharmacologically active, which can then travel to tissues binding to receptors in order to produce an effect. It is vital for drugs to reach cancer cells, but increases in tumor size result in increasing intercapillary distance, further affecting distribution. But how do we reach them? Targeting cancer cells and the building up of tumors depends on more than one signaling pathway, and pathways are important when it comes to intracellular distribution of anti-cancer agents, so binding with the target can be achieved. So in cancer patients, researchers focus on smart drugs that hit one target site in the body, compared to dirty drugs that hit multiple targets, including bad and good cells. But the problem with anti-cancer agents is that they have a narrow therapeutic index, which can lead to acute or delayed toxicity. But cancer cells have overexpression of receptors, which can maximize specificity when binding to agents. This creates problems in cancer patients where the majority are taking multiple drugs, increasing the likelihood of pharmacodynamic interactions, altering the bioavailability of anti-cancer agents in combination with other drugs when distributed. But most cancer patients suffer from malnutrition and hepatic dysfunction due to liver metastasis, which may result in decreased protein binding or drugs interacting due to competition for the same sites. In terms of the liver now, it is the most important site of metabolism, where drugs undergo hydrolysis via oxidation and reduction reactions, changing them to metabolites for excretion. Because when a drug is administered, it comes into contact with other enzymes, mediated by transporter proteins. So once in the liver, anti-cancer agents undergo phase 1 and phase 2 metabolism. Phase 1 metabolism involves the cytochrome P450 system in the endoplasmic reticulum of hepatocytes, but cancer patients have a reduced CYP450 system, so their metabolism can either inhibit or induce enzymes. The CYP450 system is also influenced by the type of tumor, as it affects rates of metabolism and the amount of drug available for bodily tissues, including drug delivery from the plasma to the tumor. Phase 2 metabolism is a conjugation reaction of glucouronidation, which means that it is catalyzed by diphosphate glucouronal transferases, but just remember UGTs. The issue with these enzymes is that they contain polymorphism, which just means different phenotypes. And if you're still confused, it's like a dark versus light jaguar, but at the end of the day, they're still jaguars. Anyways, the polymorphism decreases glucuronidation, affecting drug disposition pathways. After we have metabolized a drug, the body needs to find some way to excrete it. This occurs via biliary, so the liver, and renal pathways, so they can completely leave our system. Both pathways of excretion are processes that involve carrier systems, where it can only take a certain capacity so the rate of a drug can be excreted. Rapid excretion or poor bioavailability can terminate its full effect. However, pathways of elimination can be affected by a reduction in glomerular filtration rates, as anti-cancer drugs have a narrow therapeutic index. This low clearance of macromolecules can result in a rise of interstitial fluid pressure, which can inhibit transport of drugs due to blockage of blood flow in the body. If an anti-cancer drug has high resistance to hepatic clearance, then pharmacokinetic variations can provide an alternative pathway via the kidneys for excretion. Other factors that people tend to forget about that also contribute to variations include age, drug-to-drug interactions, herbal medicines and nutritional supplements, and food items. Age contributes to changes in body composition, organ function, and higher risks of drug-to-drug interactions. Bodily function can affect hepatic dysfunction and risk of overdose, as most of the time it is often unrecognized. Drug-to-drug interactions are of great concern as they affect drug disposition, but pharmacokinetic screens can be used to detect individual variability and various anti-cancer drug classes. Herbal medicines and nutritional supplements are a controversial area when used with anti-cancer drugs, but it has said to lead to unexpected toxic effects. Side effects can also be caused by food items. A prime example is grapefruit juice. Grapefruit juice can reduce the activity of superfamily member, the CYP3A inhibitor, so bioavailability of drugs have a high risk of enteric metabolism, and this means serum levels of the drug can increase and lead to severe toxicity. Thank you for listening to my presentation.